Exogenous insulin is needed when insulin is inadequate to meet specific metabolic needs. People with type 1 diabetes require exogenous insulin to survive and may need multiple daily injections of insulin or continuous insulin infusion via an insulin pump to adequately manage blood glucose levels. People with type 2 diabetes may require exogenous insulin during periods of severe stress, such as with an illness or surgery. In addition, because type 2 diabetes is a progressive disease, over time the combination of nutrition, exercise, and oral medications may no longer adequately manage blood glucose levels. At that point, exogenous insulin would be added as a part of the management plan. People with type 2 diabetes may also need up to 4 injections per day to adequately manage their blood glucose levels. Occasionally, insulin pumps are used for patients with type 2 diabetes. Today, only genetically engineered human insulin is made in laboratories. The insulin is derived from common bacteria such as E. coli or yeast cells through recombinant DNA technology. In the past, insulin was extracted from beef and pork pancreas, but these forms of insulin are no longer available. Insulins differ by their onset, peak of action, and duration, and are categorized as rapid, short, intermediate, and long-acting. The base of all insulin preparations is regular or short-acting insulin. The onset of activity, peak, and duration are manipulated by adding zinc, acetate buffers, and protamine. The zinc and protamine added to make intermediate acting or NPH insulin can cause an allergic reaction at the injection site in susceptible individuals. Commercially available insulin preparations showing onset, peak, and duration of action. Individual patient responses to each type of insulin are different and are affected by many different factors. The insulin regimens that most closely mimic endogenous insulin production is known as the basal bolus regimen. There is rapid or short-acting insulin boluses before meals, and there's going to be intermediate or long-acting insulin once or twice a day. Intensive insulin therapy, consisting of multiple daily insulin injections together with frequent self-monitoring of blood glucose. The goal is to achieve a glucose level of 80 to 130 before meals. Other less intense regimens can also promote healthy glucose levels for some people. Ideally, the patient and the healthcare worker or provider will work together to select a plan. The criteria for selection are based on the desired and feasible blood glucose levels and the patient's lifestyle, food choices, and activity patterns. If a less intensive regimen is not giving the patient optimal results, a more intensive approach might be encouraged by the physician. To manage a postprandial or after dinner or meal glucose level, the timing of administration of rapid or short-acting insulin in relation to meals is crucial. Examples of rapid-acting insulin include Lispro. It has an onset of action of approximately 15 minutes and should be given within 15 minutes of mealtime. It most closely mimics natural insulin secretion in response to a meal. A short-acting insulin is known as regular and has an onset of action 30 to 60 minutes, and the preparation is typically injected 30 to 45 minutes before a meal to ensure the onset of action coincides with meal absorption. Because timing an injection 30 to 45 minutes before a meal is difficult for people to incorporate into their lifestyles, the flexibility that rapid acting like Lispro is preferred by those taking insulin with their meals. Short-acting insulin is also more likely to cause hypoglycemia because of the longer duration of action. This is an example of an insulin sliding scale that corrects a patient's blood sugar prior to eating. If they're outside of the 80 to 130 or 70 to 130 where we want diabetics to be, we would give them insulin to bring their glucose down to within normal, and then also giving them food to cover what they eat. In addition to mealtime insulin, people with type 1 diabetes use a longer acting or intermediate acting insulin to maintain glucose levels in between meals and overnight. Without the 24-hour background insulin, people with type 1 diabetes are more prone to developing diabetic ketoacidosis. Many people with type 2 diabetes who use mealtime insulin or oral medications also require a basal or background insulin to adequately manage blood glucose levels. Lantus or Levemir are long-acting insulins that are released steadily and continuously and that typically have no peak of action. The action time for insulin is going to vary. Although they can be given use for once daily subcutaneous administration, sometimes they can be given twice a day. Because they lack peak action time, the risk for hypoglycemia or a reduced blood sugar from this insulin is greatly reduced. We need to remember, too, with Lantus or Levemir, we are not going to mix it with any other insulin. So we cannot mix it with a short or rapid-acting insulin. Intermediate, or NPH, is also used as a basal insulin. Its action has a duration of 12 to 18 hours. The disadvantage of NPH is that its peak of action ranges from 4 to 12 hours, which can result in hypoglycemia. NPH can be mixed with short and rapid-acting insulins, such as Lispro or Regular. We have to remember that NPH is cloudy insulin, and it should be gently agitated, not shaken, before drawing up and administering to a patient. We typically don't see a lot of NPH out in practice anymore because Lantus has become kind of the gold standard. For patients who want to use only 1 or 2 injections per day, a shorter rapid-acting insulin is mixed with an intermediate-acting insulin such as NPH in the same syringe. This allows patients to have both mealtime and basal or background coverage without having to administer 2 separate injections. Although this may be more appealing to the patient, most patients achieve more optimal glucose levels with a basal bolus therapy. Patients may mix the 2 types of insulin themselves or may use a commercially pre-mixed formula or pen. Pre-mixed formulas offer convenience to patients who do not have to draw up and mix insulin from 2 different vials. This is especially helpful to those who lack visual, manual, or cognitive skills to mix insulin themselves. However, the convenience of these formulas limits the potential for optimal blood glucose levels because there is less opportunity for flexible dosing based on need. As a protein, insulin requires special storage considerations. Heat and freezing alter the insulin molecule and make it less effective. Insulin vials and insulin pens currently in use may be left at room temperature for up to 4 weeks, unless the room temperature is higher than 86 or below freezing. We need to store unopened insulin vials and insulin pens in refrigerators. Prolonged exposure to sunlight should be avoided as it will break down the insulin. A patient who is traveling in hot climates may store their insulin in a thermos to keep it cool, not frozen. Pre-filled syringes containing 2 different insulins are stable for up to 1 week when stored in a refrigerator. Syringes containing only 1 type of insulin are stable for up to 30 days. Teach patients to store syringes in a vertical position with the needle pointed up to avoid clumping of suspended insulin in the needle. Before injection, gently roll pre-filled syringes between the palms 10 to 20 times to warm the insulin and suspend the particles. Some insulin combinations are not appropriate for pre-filling and storage because the mixture can alter the onset, action, and/or peak times of either of the types. Consult a pharmacist as needed when mixing and pre-filling different types of insulin. Routine doses of insulin are administered by subcutaneous injection. Regular insulin can be given IV when immediate onset of action is required. Insulin is not taken orally because it is inactivated by gastric juices. We need to teach patients to avoid injecting insulin intramuscularly because rapid and unpredictable absorption can cause hypo or low blood sugar. The speed with which peak serum concentrations are reached vary with the anatomic site for injection. The fastest subcutaneous absorption is from the abdomen, followed by the arm, thigh, and buttock. Although the abdomen is often the preferred injection site, other sites work as well. Caution the patient about injecting into a site that is to be exercised. For example, injecting into the thigh and then going jogging could increase body heat and circulation, which could increase the rate of absorption, speed of onset, and cause a drop in blood sugar. Teach patients to rotate the injection within and between sites. This allows for better insulin absorption. So for example, maybe for 1 week you'd want to stick within the same arm, but just make sure that you spread it out greater than a half an inch to an inch in distance away from the prior shot. And then after that week's up, you would move to another area. For example, it may be helpful to think of the abdomen as a checkerboard with each half-inch square representing an injection site. Injections are rotated systematically across the board, with each injection site at least a half to 1 inch away from the previous site. It can be helpful to inject fast-acting insulin into faster absorbing sites and slower-acting insulin into slower absorbing sites. Most commercial insulin is available as a U100, indicating that 1 ml contains 100 units of insulin. U100 insulin must be used with a U100 marked syringe. Only the person using the syringe should do the recapping. Never recap a needle used by a patient. The use of alcohol swab on the site before self-injection is no longer recommended. Routine hygiene, such as washing with soap and rinsing with water, is adequate. This applies primarily to patient self-injection techniques. When injection occurs in a healthcare facility, policy and procedure may dictate site preparation with alcohol to prevent healthcare-associated infections. Insulin injections are typically given at a 90-degree angle. For extremely thin or muscular patients in the hospital, perform injections at a 45-degree. At home, patients inject at a 90-degree angle using the shortest needle possible. Pinching up the skin to avoid intramuscular injection is no longer necessary because of the availability of short needles. An insulin pen is a compact portable device loaded with an insulin cartridge that serves the same function as a needle and syringe. Pens needles are available in various lengths and sizes. Insulin pens offer convenience and flexibility. They are portable and compact, and their use is more discreet than using a vial and syringe, and they provide consistent and accurate dosing. For patients with poor vision, the pen is a better option so that they can hear the clicks of the pen as the dose is selected. Insulin pens come packaged with printed instructions, including pictures of the steps to take when using the pen. These instructions are helpful to use in teaching new users and in reviewing techniques with current users of a pen. An insulin pump delivers a continuous subcutaneous infusion through a small device worn on the belt, in a pocket, or under clothing. Insulin pumps use rapid-acting insulin, or short-acting, which is loaded into a reservoir or cartridge and connected via a plastic tube which is inserted in the subcutaneous tissue. All insulin pumps are programmed to deliver a continuous infusion of rapid-acting insulin 24 hours a day, known as the basal rate. Basal insulin can be temporarily increased or decreased on the basis of carbohydrate intake, activity changes, or illness. Some individuals require different basal rates at different times of the day. At mealtime, the user programs the pump to deliver a bolus infusion of insulin appropriate to the amount of carbohydrate ingested and an additional amount if needed to bring down or correct high preprandial blood glucose, like we talked about with the sliding scale. Insulin pump users check their glucose level at least 4 times a day. Monitoring 8 times or more per day is common. A major advantage of the insulin pump is the potential for keeping blood glucose levels in a tighter range. This is possible because insulin delivery becomes very similar to the normal physiologic pattern.